This is a lecture on theme 20, Selected Examples of Viral Diseases. And my name is Professor Louis Nel of the Department of Microbiology and Plant Pathology. Now, the first disease we're going to deal with is rabies. So, rabies virus belongs to the family Rhabdoviridae, falls within the genus Lyssavirus. And this is a negative strand RNA virus that causes the disease rabies, which is encephalitic disease. So the virus infects the central nervous system of warm-blooded animals or mammals, and it leads to death if it's not prevented by post-exposure treatment, which needs to happen directly after exposure. So the virus enters the body through a wound or a bite, and the transmission mechanism is then via infected saliva. In humans, 9 months may pass before the onset of symptoms, but usually disease onset is within 3 to 4 weeks. So here in figure 22.12, and rabies is discussed on page 646 in the textbook. And here you can see that the virus enters tissue from the saliva of a rabid animal, and then replicates in the muscle cells near the bite and enters the neuron of the peripheral nervous system, and then moves along the peripheral nervous system to the CNS. Then the virus moves along the spinal cord towards the brain. It then reaches the brain and causes a fatal encephalitis. So from here, from the brain, the virus moves to the salivary glands and other organs of the victim. And once in the salivary glands, this victim would then be infectious and could spread the virus through the saliva, which then contain high numbers of virus particles. So this is an example of reported cases of rabies in animals in the USA. So in the United States, rabies virus has been eliminated from dogs, but it is common in wildlife. And certain wildlife species, and it's shown here, and where they occur, raccoons, especially on the eastern coast side of the US, then skunks in the central parts of the US, foxes and skunks in the south central parts, and then also in foxes in Alaska. So this is an example of rabies cases in various wild and domestic animal species. So rabies in domestic animals such as dogs and cats is uncommon because of high vaccination rates in these animals. But raccoons, skunks, and bats are the animals most likely to be infected with rabies in the United States. Now, most human cases are caused by bites of bats, again in the United States. But worldwide, most human cases of rabies are caused by bites of infected rabid dogs. This is a picture of a silver-haired bat, which may be a rabies carrier in the United States. If we look at the distribution of lyssaviruses, so these are the various different lyssaviruses, and there are 15 of them. So rabies virus is the prototype or the type species, that's number 1. And the distribution of rabies virus is global. Then we have this list of other viruses of which you don't have to know the names, but they are very similar to rabies virus, but they are mostly carried in bats and not in terrestrial animals. But for us, the most important one that we discuss in this lecture is rabies virus. And so that is the group 1 that you see at the top right hand of this phylogram. So rabies virus occurs, or rabies occurs primarily as an epizootic disease in animals. So it's an animal disease, but it can be spread as a zoonotic disease to humans. So when an animal disease is transmitted to humans, that's a zoonosis or a zoonotic disease. And again, reservoirs in the United States would be wildlife such as raccoons, skunks, coyotes, foxes, and bats. In Africa, the most important reservoir is the domestic dog. Can also get rabies in mongooses, jackals, and foxes. This is well demonstrated in South Africa, for example, and neighboring countries. But rabies is not known in bats in Africa. So that is classical rabies virus in bats. It's not known to occur in Africa. So between 60 and 70,000 people are estimated to die annually from rabies, so primarily in developing countries, and over 1 million people receive post-exposure prophylactic care every year. So this figure again shows the distribution of the various different viruses and discovery of various different lyssaviruses. It's the most important uh, to understand is that the group of lyssaviruses are quite complex, um, with several of these lyssavirus occurring only in Africa, some of them occurring only in Europe, some of them occur only in the Far East, and in Australia we've got the Australian bat lyssavirus. But the rabies virus, which is the type species of this group of viruses, occur worldwide with the exception of a few isolated places. So this is the distribution of rabies virus in South Africa. So you can see the species listed here, bat-eared fox, so the yellow, so that's mostly more the arid areas towards the western side and central side of South Africa, and black-backed jackals, that's more in the northern provinces in Limpopo in our country. Domestic canine rabies, so in domestic dogs you can see spread all over, but a very high incidence in KwaZulu-Natal and in the Eastern Cape province. And then yellow mongoose, that's the red, so rabies in mongoose, and that's more over the Free State or the central Highveld Plateau of South Africa. So rabies virus proliferates in the brain. It leads to fever. It can lead to excitation, dilution of the pupils, hypersalivation or excessive salivation, anxiety, fear of swallowing. It can also lead to paralysis. Symptoms can be very non-specific. And rabies is diagnosed using tissue samples, and it's best diagnosed by using tissue from the brain. Victims can be passively immunized with rabies immune globulin and vaccine, and this is called post-exposure prophylaxis or PEP. So the immunization takes place with the rabies virus vaccine, and then can also be treated with immune globulin to generate an effective post-exposure prophylaxis regimen. So rabies is again diagnosed in the laboratory using tissue samples, therefore is usually post-mortem. There's no test to determine rabies before the onset of symptoms. Um, the test most often used is fluorescent antibody test, but you can also use PCR or reverse transcriptase PCR. Remember, this is a RNA virus, so to do PCR, the RNA first needs to be converted to DNA. And the victim of a bite can be treated by passively immunizing with a rabies immune globulin, as well as using a rabies virus vaccine. The spread of rabies is prevented largely through the immunization of animals, and this is very important to immunize dogs in in an African setting, but as well as wildlife, where rabies is common in wildlife, for example, in Europe and in the United States. So rabies is a fatal disease, but again can be prevented by correct post-exposure prophylaxis shortly after shortly after the exposure occur. But as soon as clinical symptoms start, then the virus is already in the brain, and then there's no intervention to save the patient. Post-exposure prophylaxis also consists of wound care, so washing of the wound with soap and water is very helpful. And then again, uh, treatment with human rabies immune globulin and repeated doses of the rabies vaccine. So the World Health Organization, or WHO, have the following recommendations. So for category 3 bites or exposures, and this is single or multiple transdermal bites, so piercing the skin, transdermal bites or scratches, licks on broken skin, contamination of mucous membrane with saliva, so like licks, and suspect contact with bats, then one should use both immune globulin plus vaccine in the post-exposure treatment. Category 2 exposure, these are minor scratches or abrasions without bleeding, uh, and the nibbling of uncovered skin without penetrating the skin, then one can use vaccine alone. In category 1, that's touching, feeding of animals or licks on intact skin, there's no exposure and therefore no prophylaxis if the history is reliable. In other words, if this animal doesn't have any history of being sick, or having any signs of rabies. So rabies prevention in humans is by pre-exposure prophylaxis, so you can be vaccinated against rabies, and usually veterinarians and doctors and people working in the field with animals, they are typically vaccinated against rabies. Then we can get post-exposure prophylaxis, which is composed of wound care, immune globulin, and vaccination. And these are the schedules as they are applied in South Africa. Now, there's one example that is kind of famous of a patient who survived rabies after the onset of symptoms. And she was treated by a medical protocol known as the Milwaukee Protocol. So the patient was Gina Gisi in North America. The source of rabies was a bat. She picked up this bat in church on one Sunday morning, and she was bitten on the finger. Didn't think anything about it, did not receive post-exposure prophylaxis. And after 1 month, symptoms started to develop. No virus was found, no viral antigen, no viral nucleic acid, which is not uncommon because um, uh, once the virus has traveled through the peripheral nerves and so on, it's often very difficult to detect virus. But virus neutralizing antibodies against the virus was detected. So this was a clear indication that she was exposed to rabies virus. So this is some pictures of Gina. She made a full recovery, actually got a driver's license, and also obtained a degree at university. In South Africa, there was a fairly famous case, a young man called Graham Anderson, who was a famous sportsman. He was a world famous canoeist, and he contracted rabies from a dog. This treatment protocol, was tried on him as well, but it didn't work. It also didn't work in multiple other cases, so we're not sure why it worked in Gina Gysi's case. But he was declared brain dead after 5 weeks in a coma. So the important thing to protect against rabies is to vaccinate the reservoir species. So for us in Africa, very important um, that one should vaccinate your pets, dogs and cats. Next, we're going to talk about viral hemorrhagic fevers. We're going to talk specifically about Ebola hemorrhagic fever, and this is an example of a viral disease of the cardiovascular and lymphatic systems. The viral hemorrhagic fevers are discussed on page 686 of the textbook. So these diseases are mostly zoonotic, so they are transmitted from animals to humans. So fever, chills, headache, nausea, vomiting, quite common. And good example, Marburg in Ebola, hemorrhagic fever. Of course, Ebola has been very much in the news in the past year or two, and we will discuss that. So it's a severe, often fatal disease in humans and non-human primates such as monkeys, gorillas, and chimpanzees. It's a virus of the family Filoviridae, genus Ebola virus. The natural reservoir host for Ebola remains unknown, but it's probably zoonotic, animal-borne, with bats as the most likely reservoir. Because the natural reservoir has not yet been proven without doubt, the manner in which the virus first appears in a human at the start of an outbreak is unknown. However, it's been hypothesized that the first patient becomes infected through contact with an infected animal. And then virus can be transmitted in humans by direct contact with the blood or secretions of the infected person or animal, and exposure to objects such as needles that have been contaminated with infected secretions. So just to repeat in what the message advocated in West Africa, how do you get the Ebola virus? Direct contact with one, the bodily fluids of a person who is sick or who has died from Ebola. This can be blood, vomit, pee, poop, sweat, semen, spit, other fluids. Secondly, objects contaminated with the virus, needles, medical equipment. And thirdly, infected animals by contact with the blood or fluids or infected meat. So this is a phylogram showing the genetic relatedness between the different strains of Ebola virus at the bottom and Marburg virus at the top. So you can see there are a few different ones in among the Ebola viruses. So strain Zaire, Sudan, Reston, and so on. And this slide shows the outbreaks by species and size since 1976. So you can see mostly in Central and West Africa, notably those outbreaks in Sierra Leone, Liberia, and Gabon in recent years. The dot that you see there in South Africa was a patient who traveled from an infected zone to South Africa to be treated in a hospital in South Africa, and who subsequently uh, died in that hospital, but not after also transmitting the virus to one of the healthcare workers who treated the patient without knowing that he actually came from an Ebola epidemic area. So this gives an indication of the different outbreaks and the the countries and numbers of cases. Which is interesting to see is the percentage fatality on the right hand side. So this means the number of infected people who died. So you can see in some cases it's 100%, but those are single cases. But typically, if we look at the yellow Uganda, DRC, Uganda, then the multiple countries 2014-15, so that's Sierra Leone and so on Western Africa and DRC. So we there look at between about 40 and 70% fatality rate, which is fairly high. So a 40% chance of succumbing to the disease, 40 to 75% chance of succumbing to dying of the disease once you've contracted it. So this is the uh, suspected cycle. So bats are implicated. So between bats and wildlife, this virus can circulate, and, um, and then by some means transmitted to humans, either uh, from direct contact with infected bats or direct contact with the meat or blood of an infected non-human primate. And that would be the mechanism where the first human contracts the disease, and then once in humans, it can be transmitted between humans in the mechanisms already mentioned. So contact with bodily fluids, and direct contact, and contact with medical equipment, and so on. So in terms of signs and symptoms, so for Ebola hemorrhagic fever, this is typically fever, headache, joint and muscle aches, weakness, diarrhea, vomiting, stomach pain, and lack of appetite. It can also be some other symptoms, as you see there on the right hand side: rash, sore throat, chest pain, and so on. Can be bleeding inside and outside of the body. Symptoms in the case of Ebola may appear anywhere from 2 to 21 days after exposure, but 8 to 10 days is most common. And some who become sick with Ebola are able to recover, while others do not. So we just looked at the fatality rate of between 40 and 75%. So they so a certain percentage of these patients who become sick are able to recover, uh, but then many do not. So diagnosing Ebola hemorrhagic fever in an individual who's been infected for only a few days is not easy, because the early symptoms, including red eyes, skin rash, so on, are really non-specific to Ebola virus infection, and are often seen in patients with much more common uh, diseases. So, so non-specific. So laboratory tests used in diagnosis include an ELISA test, which is a serological test. So it's in this case called the antigen capture enzyme linked immunosorbent assay. Also PCR and virus isolation. Later in the disease, detection of IgM and IgG antibodies, and then retrospectively in deceased patients, immunohistochemistry can be done, as well as PCR, and of course virus isolation. In cases of treatment, the standard treatment is still limited to what is known as supportive therapy. So not specific treatment, but making the patient comfortable and providing fluids and so on. So timely treatment is important but challenging, again, as some of the early symptoms are non-specific. If there's a reason, however, to believe that Ebola should be considered, the patient must be isolated and public health professionals notified. So isolation very important to prevent human to human spread, which then quickly develops in an epidemic. So some experimental treatment and vaccines has been tested. Looks like they can be effective in animal models, but you still have to progress to its use or test in humans. So it's unknown exactly how many people are infected with Ebola. Um, there are few established primary prevention measures. So when cases of the disease appear, there's increased risk of transmission, so isolation becomes important. So also have the capacity to request diagnostic tests or prepare samples for shipping and testing elsewhere where the capacity exists. So barrier nursing techniques, including the wearing of protective clothing such as masks, gloves, gowns, goggles. Um, the use of infection control measures such as complete equipment sterilization and routine use of disinfectants and isolation of Ebola patients from contact with unprotected persons. So just some of with the outbreak in West Africa in 2014 and 15, there's a lot on the news. Can still find it because it was really a very frightening experience, and it took a large scale intervention to bring that epidemic under control. And you can see why it's very difficult to work with these viruses because they have this high mortality rate. The you have to use protective clothing and work with the virus under these very high security conditions, such as you can see here in what is known as a level P4 laboratory. That's the highest level of containment laboratory that you can get. Some more pictures from the laboratory in South Africa, and more examples of how one goes about working with this virus. Next, we're going to look at the virus causing the common cold. And so this is discussed on page 706 of the textbook, and it's an example of a viral disease of the upper respiratory system. So common cold is characterized by sneezing, excessive nasal secretions and congestion. It's normally no fever, and it involves the upper respiratory tract. This is caused by different viruses, most commonly rhinoviruses, 30 to 50% of cases, and also coronaviruses, 10 to 15% of the cases. So these viruses are airborne and they are spread through direct contact. So contact with infectious particles, direct contact. Antibiotics are ineffective to treat viral infections. They can treat bacteria but not viruses. So there are more than 200 viruses that can cause a common cold. So you can think that vaccines would not be a feasible option because there are more than 200 viruses. So what do you vaccinate against? Because remember, vaccines are very virus specific. Next, we're going to discuss influenza. flu virus or influenza virus, which is discussed on page 721 of the textbook, and this is an example of a viral disease of the lower respiratory system. So symptoms of flu includes chills, and in this case fever, not so for the common cold, but fever, headache, and muscle aches. There's usually no intestinal symptoms. Flu can be dangerous, so there's a 1% mortality uh, between 250 and half a million people a year. 250,000 and half a million people a year. But mortality is usually occurs in the very young and very old people. So this shows the structure of influenza virus. It has this envelope with two types of proteins on it. So that green protein is called the neuraminidase, or NA spike. The blue triangles are called hemagglutinin, or HA spikes. And then we have the capsid, and inside the capsid we have the RNA, which consists of 8 different pieces of RNA, each within its own helical capsid. So the hemagglutinin or HA spikes, they are used for attachment to host cells, and usually antibodies are directed against hemagglutinin proteins. And these are also detected if you use the hemagglutination inhibition test for virus detection. The neuraminidase spikes, they are used to release viruses from cells, and they can also stimulate the formation of antibodies. Since both of these proteins, hemagglutinin and neuraminidase, occur on the surface of the virus. So viral strains, the different strains of flu virus or influenza virus, are identified by the variation in the hemagglutinin and the neuraminidase types. So here you see, for example, different influenza serotypes. We've got influenza type A, type B, and type C, all infect humans. Then you can see the antigenic subtype. So in type A, for example, H3N2, H1N1, H2N2, H3N2, H1N1, in the emergence in different years, as you can see there in the next column, as well as the severity. So type A is most common, and these are the known outbreak strains in humans. So in influenza, we get two types of changes in the viruses from year to year. So the first is called antigenic shift. So this is a very dramatic change. This is where we get changes in the hemagglutinin and the neuraminidase spikes. And this is due to genetic recombination between different strains while they infect the same cell. So you've got two different viruses infecting the same cells, and then their genetic material can recombine and they form a new type of virus. And this is very dramatic change and can cause major epidemics. The second one is antigenic drift. This occurs naturally from year to year, where you have the accumulation of certain mutations, point mutations in the genes that encode hemagglutinin or neuraminidase spikes. And if such mutations occur, it may lead to changes in amino acids, and sometimes only just one amino acid, and can allow the virus then to avoid uh, previously made mucosal IgA antibodies. So you will not be resistant to the infection of such a slightly different looking virus, which is why one can get flu multiple times. And you know, when you recover from flu, you're not necessarily protected the next year, since the new strain might look slightly different. So just to show how this antigenic shift can work, so in this case we have then a reassortment process, so a major change where you have two different types of viruses infecting the same host and the same cell in that host. And you can see from these, so you can see 8 different pieces inside each of these viruses, and these 8 different pieces in the case of a bird virus and the human virus are either orange. But when both of them infect the same host, same cell, and they mix these pieces of genetic material, you will have a new virus that contain both orange and blue pieces of genetic material. So this is a reassorted virus and a new virus. A good example is this H1N1 virus, which caused quite a recent scare when this virus first appeared. So in this case, it's an unusual cocktail of avian, swine, and human viruses. So again, a bird virus, a human virus, infected in pigs, and where pigs are able then to harbor several flu viruses at the same time, and then these pathogens mix to create a new viral strain, and then spread from pigs to humans by inhaling the virus particles. And once the virus is transmitted into humans, you then get much more common human to human transmission, again by inhalation of virus particles. So there are no vaccines that provide long-term immunity because the viruses change so frequently, as I just explained, either through antigenic shift or then more commonly through antigenic drift. So what we do in South Africa is that new strains should be identified by February to develop a vaccine in time for distribution, because the hive time for flu is in our winter months. So by February, we need to have the right vaccine already. So there are many centers to collect epidemiological information. The information is then used to decide on which multivalent vaccine to use. Multivalent meaning you put several different viruses in there so that you can enhance your chances of creating immunity in the patient. In this case, viruses must be grown in embryonated eggs. So for flu diagnosis is also difficult from clinical symptoms, and if you want to be sure, it should be confirmed with a laboratory diagnostic technique. Treatment can be inhibitors of virus replication, uh, specifically by inhibiting the virus neuraminidase, and a common name for such a compound is Tamiflu. So next we will discuss mumps as an example of a viral disease of the digestive tract. And this is discussed on page 751 of your textbook. So mumps virus cause swollen parotid glands, and then occur in saliva and respiratory secretions. Incubation for mumps is about 2 to 3 weeks. Diagnosis is through symptoms, but also through virus isolation or enzyme-linked immunosorbent assay. There is a preventative vaccine these days to prevent mumps, and this is called MMR. So this is an example, figure 25.14, a case of mumps, and you can see the swollen glands. So finally, we will discuss hepatitis as an example also of a viral disease of the digestive system. In this case, hepatitis refers to an inflammation of the liver. So hepatitis viruses specifically infect the liver cells. So such an inflammation of the liver can result from different toxicities, but also various viruses such as Epstein-Barr virus, cytomegalovirus, or then the hepatitis viruses. So here you have the different hepatitis viruses of humans. So hepatitis A, B, C, D, and E. And they are all very different viruses. They belong to different families, and they have the infection by these different viruses can be quite variable in severity. So let's deal with hepatitis A. This belongs to the family Picornaviridae. It's mostly subclinical, a little bit of fever, general tiredness or malaise, and it's not a chronic disease. Incubation 2 to 6 weeks. How do you get it? You ingest it. So this is from contaminated water or contaminated salads or vegetable, but it's a waterborne disease then in that sense. Can be treated by immunoglobulin, and you can be vaccinated against hepatitis A, and it's often recommended, particularly if you travel in the developing world. Hepatitis B is a completely different virus, belongs to the family Hepatnaviruses or Viridae. It's frequently subclinical. It's much more serious disease. It's likely to progress to severe liver damage and chronic disease occur. 4 to 26 weeks incubation period. The method of transmission, how do you get it? Most commonly through sexual contact. A diagnostic test is IgM, and treatment can be with interferon alpha, so interferon, and you can be vaccinated with a genetically modified vaccine that is produced in yeast. Hepatitis C is a different virus, belongs to the family Flaviviridae. It's kind of similar to hepatitis B virus in terms of symptoms, and also likely to become chronic with the incubation time of 2 to 22 weeks. So the method of transmission is parenteral, so that means by injection. So often seen in drug abuses. Diagnostic test is PCR. Can be treated with ribavirin, but no vaccine. Hepatitis D belongs to family Deltaviridae. Severe liver damage, high mortality rate. Its incubation period 6 to 26 weeks. Parenteral, again, so through needles, but it requires co-infection with hepatitis B. So the two need to go together. Hepatitis D is dependent on the presence of hepatitis B. So these two must be together. And there is a vaccine for hepatitis B virus, which is then also protective against this hepatitis D or delta. Hepatitis E virus belongs to the Caliciviridae. It's similar to hepatitis A virus. 2 to 6 weeks incubation period. Again, get this through ingestion, so contaminated water and food. PCR can be used for detection or antibodies, and the hepatitis A virus vaccine actually also protect against hepatitis E virus. And that brings us to the end of the lecture on selected examples of viral diseases. So we looked at rabies as an example of a viral disease of the nervous system. We looked at Ebola hemorrhagic fever as an example of a virus disease of the cardiovascular and lymphatic systems. We looked at the common cold as an example of a viral disease of the upper respiratory system. Influenza is an example of viral disease of the lower respiratory system. And then we looked at mumps and hepatitis as examples of viral diseases of the digestive system. Thank you.